Good evening, everyone. Welcome to the 95th session of the weekly huddle. Most of the participants today are familiar with the format and the program that we've been doing for quite some time. After 2 week break, we rejoined with our weekly discussions. And what we left the 2 weeks before with Dr. Vijay Kumar about the positive airway pressure and its role in obstructive sleep apnea syndrome, followed by its role in heart failure subset of patients. So we thought we will continue the discussion which was suggested by him. So today we are going to talk about this discussion. My name is Dr. Praneeth Polumuri. I'm a cardiologist working at Care Hospital, Banjara Hills. I'm joined by my co-host, Dr. Anoop Agrawal, who is also a cardiologist working with me at the same place. We both are doing this session. Essentially, we select a topic which is encountered in our day-to-day practice. We do this discussion trying to share our thought process and learn from each other about practice patterns of these various clinical scenarios. Today, one such case is that we encountered recently in relation to heart failure. I will start my case. I will take few comments from my co-host, take few comments from other participants as well, and we take expert comments from today's guest, Dr. Vijay, who is a senior pulmonologist, who will add insights on this case and equally add a few more comments on how do we manage. So this case is a 60-year-old male who is hypertensive diabetic, who previously had an Agrawal MI about 2 years back, and he underwent revascularization. It was a delayed presentation, and he ended up having LV dysfunction. So it's an ischemic cardiomyopathy. His baseline ejection fraction is 30%. His LV dimensions are 5 by 6 centimeters, and he is reasonably well preserved in terms of heart failure management, where he is given the so-called guideline and directed medical therapy in terms of single antiplatelet, statin, ACE inhibitors, beta blockers, and other guideline directed therapy. He is on regular follow-up, and he was fairly in class 2 symptoms. Recently, he had traveled to one of his villages where he had a party to attend a function, and with the travel, with the change of diet, etc., there was an issue, and he ended up having a heart failure hospitalization. And from there, he got shifted. So when he got shifted, he was in frank pulmonary edema. So immediately when he was received in emergency to stabilize his condition, he was started on non-invasive ventilation therapy, the pressure support mode, in addition to the decongestive therapy, vasopressors, etc. He made a quick recovery with a stay in ICU for 24 hours, relatively better, but he was still a bit hypoxic with the requirement of NIV. In view of financial issues, he wanted to have an early exit from the hospital. So to facilitate his early discharge, we suggested him in consultation with the critical care consultants to use the NIV support for some time, which will help him transit from this heart failure hospitalization and prevent a repeat heart failure hospitalization. So this patient was discharged with a home BiPAP support, which he rented, and with the adjustment of medication, he was discharged back with a follow-up of 1 week. After 1 week of follow-up, he was doing fine, and he was compliant with the CPAP, the BiPAP therapy, the auto BiPAP, which was suggested. And because he rented for 1 month, the first question that he asked was whether what to do with the BiPAP therapy, whether I continue or I stop. Just because he rented it and he was comfortable, we suggested him to continue the CPAP therapy and review again after 1 month, and with modification of the drugs. Now, this is 1 month after this follow-up. When he comes back now, kind of again in class 2, with most of the drugs being reasonably adjusted as per his previous dosage that he was taking. He's still continuing CPAP therapy, and the question that he asked me was the same questions which came up to mind, and these are the questions which we want to discuss in today's session. So this patient who has a heart failure with reduced ejection fraction, who got decompensated and who was advised to take the positive airway ventilation support at home. When should we discontinue this so-called CPAP in this patient? Now that he is stable, does he require a CPAP still to be used, or we can stop? And because this patient responded with therapy, and we all know that patients with heart failure have associated sleep disordered breathing in terms of Cheyne-Stokes breathing or central sleep apnea. What are the recommendations of advising polysomnography in these heart failure patients? And whenever we advise CPAP therapy to the patient, what are the hemodynamic changes that we expect in these patients with the usage of positive airway ventilation? And how do we need to modify the so-called heart failure medications in these patients when they are using the CPAP therapy? So these are the questions that came up to us in this discussion. So these are the things that we would like to discuss in this session, and probably anything else that comes up as a part of the discussion. So I'll start with my co-host Anoop. I believe he is there to give his comments, or else we'll move to another one. Anoop, are you there to give any comments?
I am online, but I don't know if my network will allow me to speak. Am I audible?
Yeah, right now you are audible, so you can quickly give your comments. So Anoop, I can't get you. So I'll get back to you once your network is stable. I'll move forward.
Yeah, so in this particular patient, typically patients, they don't like to be on CPAP for a long period of time. Yeah.
Right.
Sure. Yeah, please continue.
Okay. All right. I'll go through the list. We have Dr. Santosh. Santosh, if I may request you, what are your thoughts on this case on CPAP, usage of CPAP in relation to heart failure patients? What do you think? Dr. Santosh?
Hello, sir. Am I audible?
Yeah.
Sir, just one question, sir. What has caused failure admission in this patient, sir, now?
So the exact indication for his heart failure decompensation is not clear, but the thing that we think is that dietary restriction in terms of salt and water because of his travel and his visit to his native place to attend a function. So that is what was obviously evident. He was still taking his medication. He denied any skipping of any medications, and there was no obvious infection or other ischemia.
Okay. During this travel, he must not have used, obviously, all these days the CPAP, right, sir, at night?
No, he was never on CPAP before this admission. It was in this admission that he experienced the usage of CPAP therapy.
Okay. I think, sir, if we have, I think it's better to do a paste in this patient to document AHI, how much apnea and hypoxia index is there. I think we all know that one of the risk factors for this failure, if you're not clear, is your sleep apnea. And I advise in him the CPAP therapy and plus to document how severe the OSA is.
Okay.
And the duration, again, how long one needs to continue, that I'm not sure, sir.
Okay.
So even if the patient is recovered from the heart failure, and how long one needs to continue, I think that depends upon if once on the PH report, if it is severe enough, then it's better to continue as long as it's comfortable on that, sir.
Right. So I get what you are trying to say, Santosh. So for this patient, I won't say he is grossly obese, but he weighs about 90 kgs for his height of 5 feet 7 inches. So he probably has symptoms or features of obstructive sleep apnea syndrome, though he denies any symptoms of snoring. We also try to look at his asking with his sleeping partner about his symptoms of snoring to try to get a diagnosis of obstructive sleep apnea syndrome. Though I believe that he might having, but so far clinically or based on the history, we could not get any evidence. But I get your point that we need to rule out obstructive sleep apnea syndrome, which could be there. I will try to take comments from other before I come to our guest today. I think Rajinder is there. Rajinder, what do you think on this thing? What is your experience in relation to heart failure and usage of CPAP therapy on a long-term basis?
Good evening, sir. Yeah,
Good
on
evening.
long term, people are quite reluctant to use it, but yeah, for acute settings, CPAP really helps, especially in those with heart failure, who have borderline hemodynamics, who are not able to tolerate diuretics. They have a rising trend of creatinine, and we are facing a dual jeopardy. On one side, there's heart failure symptoms, other side, there's increasing trend of creatinine. So yeah, it helps to tide over those conditions. But yeah, in terms of long-term usage, and especially with patient compliance, and basically we need to fix up the precipitating factor. So if we are sure that it's heart failure, ultimately CPAP has a role, definitely in refractory heart failure. But yeah, ultimately we need to see the precipitants and make sure that patient can comply with it. So what is the basic etiology, what is precipitating it, and how religiously is following the salt restriction, water restriction, and compliance with his diuretic management. So yeah, I have been using with CPAP in patients acute heart failure, and it has worked well. But yeah, in long-term usage, patients on my follow-up had been reluctant. Thank you so much.
Rajinder, before I let you go, I hear what you are saying that probably as an add-on therapy for a patient who has progressed to an advanced stage in terms of increasing the dosage of diuretics, etc., probably CPAP therapy may help as an additional support in relieving breathlessness. But this patient who is relatively a good patient, who is compliant with the therapy and who is compliant with the thing, and this is only the first heart failure hospitalization for him, and he kind of recovered back. The only question is that the same CPAP therapy which was started, the question that I have it for you is, do you advise him to continue or stop? And if you think that, do you rely on any investigation which probably will help you make this decision?
Yeah, biomarkers might give a clue. So NT-proBNP, if he is not on RNA, so it might give us a clue and direction. But these are not foolproof, given with the usage of increasing use of RNA. So yeah, with a pinch of salt, the biomarkers might help.
Okay, sure. Thank you. Maybe I will try to take comments from Dr. Vijay, and with whatever points that he adds up, we'll probably continue the discussion. Vijay sir, I would invite you to take over this case on this patient with whatever questions that I had in this mind, and probably you can equally enlighten us on the role of CPAP therapy in heart failure patients. Over to you, Vijay sir. Vijay sir. I think Dr. Vijay sir, am I audible? I think there seems to be some issue. Okay.
Sunny, can you hear me?
Yeah.
Okay, so
Yes,
while Dr. Vijay logs in,
Yeah,
you
I
want
had
me
to
to say
unmute.
Yes.
Yeah, sorry.
Yes, yes.
Yes, yeah, Vijay, sir, please go ahead.
Yeah.
Thank you, sir.
So sorry, I didn't unmute.
Got it.
As a pulmonary and critical care person, I have been noticing that there is an increasing number of patients coming with heart failure. And even the public is now aware about its life-threatening aspects. And probably because of very good cardiac care being given to those patients who have MI, and post-MI outcomes are much better. And as a result, patients are living much longer. And we get people who are 70 plus having heart failures, which was not the case before. And despite the recent advances in pharmacotherapy for heart failure, we still see a lot of morbidity and mortality. So as far as this particular patient is concerned, I noticed that he's 60 years, diabetic, hypertension. He had PTCA, stenting, and LV dysfunction with ejection fraction of 30%. And he's on very good pharmacotherapy, good treatment. Maybe something went wrong when he went to his village, maybe excessive salt, excessive water, despite being compliant with the treatment. And luckily, the non-invasive ventilation has helped him. How it helped him, of course, we will discuss with a different question. And once he improves, and by the time whatever decomposition has occurred, was treated with the diuretics, etc., and he got better. We say he got better because there are no crepitations, basal crepitations at the lungs. There is no pedal edema, and his oxygen saturation has improved on room air. And with this, we can say that his heart failure has improved. So in such a situation, NIV ceases to be useful. Many years ago, when a patient with a similar situation came to the hospital, we used to intubate him, ventilate him, and put him on a PEEP. And patient used to improve. And maybe after 2 days or 3 days, patient was getting extubated, and he was sent home with pharmacotherapy. Now, non-invasive ventilation is very similar to the mechanical ventilation. The only difference is here there is no endotracheal tube. Patient is being ventilated with a mask. And of course, here we have to make a distinction when we say non-invasive ventilation. It has got continuous positive airway pressure. That is one method. Another is bilevel positive airway pressure, where the inspiratory pressure is higher and the expiratory pressure is lower. And usually the expiratory pressure is 1/3 of the inspiratory pressure. The difference between the inspiratory pressure and the expiratory pressure is the pressure support, which we use in the mechanical ventilators. And the expiratory positive airway pressure is equivalent to the peak. It is the same thing, but when it comes to NIV language, we use the term EPAP, but when we talk about mechanical ventilation, we use the term peak. So it does the same. Thing. So once the patient's decompensation is taken care, and the pharmacotherapy has taken effect, and patient is asymptomatic and is doing very well, there is really no big role for a CPAP or a BiPAP to be used at home. Just like the mechanical ventilations, once he's extubated, that's it, he goes on drugs. So yes, NIV in a heart failure patient should be continued in 3 conditions. If the patient has got COPD, and COPD acute exacerbation has worsened his heart failure, if the patient had sleep disordered breathing, and that is what has happened in this patient, maybe he had 1 or 2 extra doses of alcohol, and then he went into a severe sleep apnea. So obstructive sleep apnea, like Dr. Pradeep mentioned, central sleep apnea, like chain stroke breathing, has to be ruled out. And the third condition where a CPAP or a BiPAP should be continued in a case of heart failure is obesity. Obesity, hyperventilation syndrome, hypoventilation syndrome, I'm sorry. So in these three conditions, continuing the CPAP on a domiciliary basis for a patient who has been discharged from the treatment of heart failure from the hospital is definitely indicated. And like Dr. Pradeep mentioned, all these patients must undergo a sleep study because sleep apnea can aggravate heart failure. We do not know. And in heart failure, patients can have chain strokes breathing. So these things can be detected when we do a polysomnography. And in such a case, if there is evidence of central sleep apnea or obstructive sleep apnea in terms of apnea hypopnea index being greater than 10 per hour, then these patients should be advised to use CPAP. One of the reasons why patients say, sir, can I stop using CPAP? Or some patients are non-compliant, not very happy, is because they don't find any big relief from using a CPAP. They will find a big relief if they have COPD, if they have obstructive sleep apnea, or if they have obesity hypoventilation syndrome. So it is important for us at the time of discharge that we recognize whether our patient has got any one of these three things. Yeah, I can stop here and then maybe.
Yes, sir. Yes, sir. Thank you for elaborating that, sir. I hear what you said. There are a few questions which came to me while you were saying this. So your 3 points were excellent. Now, few questions which we encounter as a regular practice, which I would like to get answered. So one thing that is a learning point is that most of these patients should undergo a sleep study. But the questions is on practical issues on ordering a sleep study. One is how do we order a sleep study, because most of the hospitals, or at least the hospital that I work, does not have an in-house hospital, and we have to depend on the third party things. And I believe there are different levels of sleep study. I think basic thing and a complete thing. So if you can highlight us specifically what are the things that we should ask the vendor to do, and the same thing probably that we should tell the patient that this is what you are expected, or this is how it is anticipated, so that the patient is well prepared of what actually is this sleep study, so that there are no surprises. So can you please help us in telling what to order, how to order, and what to tell the patient when a sleep study is being ordered?
Yeah, I agree with you that many hospitals do not have a sleep lab. Some do have it, but then it also becomes a little expensive to do the sleep study in the hospital. But doing a home sleep study is good enough, where we are measuring apneas, hypopneas, and where we are measuring the oxygen saturation trending, and where we are able to pick up respiratory effort related arousals, and also where we are able to see the sleep quality. These are good enough, and these can be done with a simple device at home by these vendors. And they can give a nice good printout with a computerized summary, which is good enough for us. So I think we should go for that. Higher levels of sleep study will stage the sleep, like stage 1, 2, 3, 4, and REM and non-REM, which really may not be as important for us from the standpoint of treatment.
Yes, sir.
Yeah.
Yes, sir. So one question which Anoop asked is, what is the accuracy of the polysomnography in a patient who just recovered from a heart failure decompensation? So when should we time the sleep study in this patient, sir?
I think um, the points that we use to make sure that the patient is good enough to be transferred from the ICU to the step down, and also the points that we use to decide whether the patient is good enough for discharge to go home for domiciliary treatment are good enough reasons for ordering a sleep study. So in no way, because his heart failure from which he has recovered will come in the way of the quality of the sleep study.
Okay, sir. And sir, other things that I have is when we get these patients to be having associated COPD, be in terms of previous history of smoking, and for patients who were previously diagnosed to be having some obstructive sleep apnea syndrome who haven't previously used. When we order patients to use this PAP therapy, sir, the first question is when to choose CPAP versus BiPAP, or which patient should deserve which one? Any particular thing that we should look into it, sir?
American Thoracic Society and European Respiratory Society have published their guidelines about non-invasive ventilation. They say for a straightforward heart failure, for a acute decompensated heart failure, CPAP is the choice, and it gives level 1 evidence in favor of that. If the patient has got acute exacerbation of COPD and also heart failure, then we should go for a BiPAP. Because here we want to use a pressure support to increase the tidal volume. By increasing the tidal volume, we can increase the minute ventilation. By increasing the minute ventilation, we can take away the carbon dioxide from his lungs and also rest the diaphragm and also improve the oxygenation. Whereas in heart failure, we are only targeting a continuous positive airway pressure, which is similar to the PEEP, where we are trying to squeeze the alveoli and we are trying to squeeze the water out of the alveoli and the interstitium and allow more and more collapsed alveoli to be oxygenated. So CPAP is good enough for heart failure, and BiPAP is the one which we should select for patients who have heart failure plus COPD, heart failure plus probably hypoventilation, obesity syndrome.
Very valid, sir. And the other question is that do IPAP pressure settings need adjustments when we use for isolated heart failure versus one used for COPD or OSA, sir? This question comes in relation to the, again, the question which equally I had is the auto CPAP or the auto BiPAP, which is what is being commonly prescribed where patient is given and it kind of takes care of itself where there is not much of involvement from the patient because they are staying away. Probably this is in relation to the question which equally Anoop asked. So can you help us in knowing what is this settings that we need to use?
For straightforward standalone heart failure, continuous positive airway pressure is the answer. And we can go for a fixed CPAP, that is something like 10 centimeters of water pressure. And since we are going to use the CPAP maybe for a few hours or for a day or at the most for 2 days, and this doesn't require any adjustments in the pressures. They get better. The water is squeezed out of the interstitium and the pulmonary edema improves, oxygenation improves, and his respiratory fatigue comes down, and thereby heart failure improves. Whereas for patients who have to use the CPAP for their obstructive sleep apnea for a long-term basis, on a long-term basis for several weeks, months, and years, there the pressure requirements may vary from night to night. So that's the reason why an automatic CPAP machine may be more desirable. And what we have observed in practice is, although it is an automatic CPAP, the pressure variations have not been very great. It is ±5 or ±3. So there is one group of people who believe that there is no big difference between an automatic CPAP machine and a fixed CPAP machine. And by and large, most patients require a pressure of 10 centimeters of water pressure.
Okay, sir. The other thing which commonly is a problem is about whenever a CPAP therapy is recommended. One is, of course, the hesitancy of using this machine to use while they are asleep, and the claustrophobia which is associated with the use, which is one of the reasons quoted for not using this CPAP therapy. So what could be the commonly used tips and tricks, sir, which you help the patients improve the compliance, where they can kind of get a hang of this machine and use it, so that once they actually use it and feel the difference. One point you said is the careful selection of the patients, that it is not for everybody, and the mode that we use, like what you said about CPAP for a heart failure patient or versus who has an associated COPD choosing BiPAP, that I got it. In addition to that, but still there is a bit of a hesitancy. What are the few tips and tricks that we can help us, where we can help the patients to improve their compliance?
Yeah. So just like mechanical ventilation, even for a non-invasive ventilation or applying a CPAP or a BiPAP, we need to take a consent from the patient and also sit next to the patient and explain to him that we are placing a mask on your face, which is going to give a blast of air, which may feel little uncomfortable, and it may take a while, maybe about half an hour or 1 hour, and you will get adjusted to it. And once you gain the confidence, once you counsel the patient, talk to the patient, hold his hand, etc., and then put the mask on his face, generally they accept. And one very, very important tip is, when we place the mask, there is a tendency for the respiratory therapist or the nurse to immediately start tightening the straps. That should not be done. So we have to just place the mask, put our hand on the mask, and then tell him that if you feel uncomfortable, I will remove the mask. But I'm here with you, I'm holding the mask for you. And then you start the CPAP machine, and the pressure with the 10 centimeters of water pressure will be blowing continuously during the inspiration and during the expiration. And patient, since we are sitting next to him, holding his hand, his claustrophobia or his hesitation will be less. And once he's comfortable, after half an hour or 1 hour, he starts feeling the improvement, because the improvement will start occurring within the first 2 hours. And he will be able to appreciate that this mask is giving him relief. And it is when you have to gently tighten the straps. And here again, we have to use what is known as a 2-finger rule. Put 2 fingers on the forehead, and above that, you have to tighten the mask or the strap. We should not tighten it too much, because this is a silicone mask. The more you tighten it, the silicone will undergo folds, and then there will be air leakage. And then all the pressure, all the air that is coming out of the machine will get wasted. So that's the reason why we have to make sure that the straps are not too tight and the mask doesn't undergo folds, thereby giving rise to leakages. Although the newer machines are equipped to take care of the leakages, they compensate the leakage to the extent of 15 to 20%. So, but then it is better that not to have the leakage at all in the first place. Same thing happens at home also. We have several masks. One mask is known as the nose and mouth face mask, where it covers most of the face, which can produce a little bit of claustrophobia. Then you have only the nasal mask, where It's a very tiny mask which covers only the nose, so that that much of claustrophobia is not there, and it is quite effective. Now, the recent addition is the air pillows, nasal pillows. So it goes into the nostrils, very soft silicone ones, and they are very soft. That's the reason why they are called pillows. And a gentle strap is put on the face, and it equally effective in delivering the pressure. So in these ways, we can take care of the claustrophobia and also the hesitation of the patient.
So the efficacy of the mask, be it nasal or nose, and covering both the nose and mouth, is more or less the same thing, sir? No
They're
difference?
same. Yeah, studies have shown head-to-head comparison between the in all these masks. Only thing is, in the hospital, when the patient is acutely decompensated with heart failure, it is always better to use a full face mask, that is, which covers the nose and the mouth. Because if the patient keeps the mouth open, then whatever air that goes through the nose will come out of the mouth and gets wasted. So it is better that we use a full face mask which covers nose and mouth in the hospital, in the ICU.
Yes, sir. The normal scenario that happens in practice is that when patients are diagnosed, because these machines are most of the time on an OPD practice not tested, the practice is to give the number of a vendor where the patient calls the vendor, and the vendor comes home and delivers the machine, and probably adjusts and gives the counseling for the patient. How much do you think that they will be doing the job properly of what you have already suggested, sir? And do you think we should be checking or follow up these patients that things are happening fine? And if we have
Yeah.
to do, what are the things that we should ask these patients that things are going fine, sir?
Yeah. Unfortunately, only 1 out of the 10 vendors are familiar with all these the science behind the NIV and the masks. So what we can tell the patient is, look, there are different varieties of masks, and you can ask the vendor to show him all the varieties of the masks so that he can pick and choose the mask that he likes. There are advantages and disadvantages. But also the air nasal pillows are more expensive than the full face mask. So, but then it is an investment for comfort.
Right.
And yeah, so it is better to go for a good company. There are currently only 3 companies which are manufacturing the CPAP and the BiPAPs. But there have been some issues with the 2 companies, and as a result, only 1 company is able to give the product in the market, and that is ResMed.
Yes, sir. And I think you said that was the first company which started manufacturing these things, and probably still
Yes.
the providing the services. And
The other company,
yes, sir.
yeah, the other
Please, sir.
company was Philips. So they had used some foam material for their filters, and this foam material has entered into the lungs of the patient. So this was recognized and this was reported, and as a result, the Philips company has recalled all the devices in the entire world back to the factory, and they had to go for a different kind of a material for their filter. So this has sort of dented their popularity, and it is now off market. It might take a few more months for Philips to come back into business.
That's scary to hear, sir. I didn't know that. That's so scary. Because many of the patients were actually using Philips machines. So I think probably for those who are using, we should ask them to check whether their machine is working fine. I think that's definitely interesting information. And sir, like if we have to kind of make it easy where we are not too much following up the patient and you want to ensure that the patient is getting the best therapy, what would be your recommendation of the company or the person that we should do, sir? Because as I understand now that there are so many details that we need to pay attention to, and I believe these are for sure being missed, because most of the time it is most of them are lay people who are actually kind of distributors who are trying to act as a respiratory therapist, though they are not qualified. But if we have to rely any few things that that we should kind of can give their number and be rest assured.
Surely, Dr. Pranit, I can do that. I can WhatsApp the message to you,
Sure, sir.
and probably you can scatter it to the people who need it.
Yes, sir.
And it may not be out of place now to tell you that there is an app called Pulmo at Home. Here, the pulmonologist will go to the house of the patient to see the patient. And along with this Pulmo at Home, there is also a respiratory therapist who will go to the patient's house to supervise the devices, the oxygen, the nebulizers, the CPAPs, the BiPAPs, etc. So this is an app which is getting introduced very shortly in Hyderabad, so that about 75 respiratory therapists will be on this app, and nearly 150 young pulmonologists will be on board of this app. So all that the patient has to do is book an appointment on the app, and the nearest pulmonologist and the nearest respiratory therapist will go to the patient's house and take care. And this is only for review patients, not for the first-time patients.
Okay. Sir, is this is this app functional at this point of time, sir, or is it still in the process, sir?
Yeah, it is just getting ready. It is going through a beta phase.
Okay, sir.
So once the beta phase is over, I think it will be available on the Google stores.
Wow. Sounds very interesting, sir. Like the concept of urban company, pulmonologist also being available on an app. I don't know whether this is good or bad in terms good for the patient, obviously, but I don't know whether to compare ourselves as a technicians, but definitely makes life easy for a patient. I think very innovative thought, I should say.
This was based on the experience that patients who have already been seen, reviewed, investigated in the hospital, they are a little reluctant to go for the second or a third visit, because many of these people are on oxygen, on wheelchairs, they are living alone, and the distance is quite far, and they may have to spend almost half a day or 3/4 of a day. So here there are a lot of young doctors who are ready to visit the patient, so they get benefited. When the patient is seen at home, the patient is benefited, and the senior consultant to whom the patient belongs also gets paid, because prima facie it is his patient, so he has a vicarious responsibility for the patient. So in the app, the senior consultant also will be able to see the changes that have been made in the treatment.
Interesting, sir. Very interesting thought process. Please let us know once this app is in force, sir. I'm sure this will be benefited for most of the patients.
Sure.
Definitely
Sure.
an interesting idea.
Yeah.
I think my questions, most of them are answered. I think I'll open the discussion. Anoop has his hand raised. Anoop, over to you.
Yeah, Pranit, am I audible?
Yes.
Okay, so my question to Vijay sir is regarding the CPAP therapy at home for heart failure. What has been very clear in today's discussion is that once the acute episode resolves, and if there is no sleep disordered pattern that we have identified, like a chain stroke breathing or central sleep apnea, which are quite common in heart failure, If these things are not identified, then it doesn't make sense to continue CPAP therapy for a long period of time. I remember in the last discussion when we were talking about OSA, obstructive sleep apnea, we were talking about patients who have a certain phenotype of OSA who may not get picked up on the sleep study, where the sleep study may come actually pretty reasonably okay. But these are your classic phenotype of sleep apnea, like, obese patient, particularly with central obesity, with short neck, with snoring feature and whatnot. And these patients, you can actually smell that they have sleep apnea, even if the sleep study says otherwise. And you often end up recommending CPAP therapy for them, even at home. Can we identify some kind of phenotype for heart failure patient as well, where we don't rely upon sleep study, where we think that these are the patients whom, regardless of whether sleep study says there is change stroke breathing or not, or whether there is central sleep apnea or not, these patients should be put on CPAP therapy for the rest of their life, primarily for heart failure treatment? Can we justify an action like this? Do we have a clinical pointers that we can use to pick up such patients? Praneeth, I hope I was audible the whole time.
Yes, Anoop, we can hear you. I think Vijay sir will answer the question.
Are there any other responses? I mean, if you can smell sleep apnea in a patient, I'm sure the sleep study will also show that there is sleep apnea. Not doing a study, not doing a test, not recording, not documenting, but advising treatment, I don't think would be appropriate. Patient compliance also will be very difficult, because you need to tell the patient you have sleep apnea. That's the reason why you have to use a CPAP machine. But if you don't have a data, you don't have the study, then it will be very difficult to convince the patient and get it done. And currently in the literature, we don't have data which suggests a continuous use of CPAP machine in heart failure patients. Only it is for acute decompensated heart failure. Although CPAP is relatively non-invasive, I'm familiar that there are other methods for heart failure, like cardiac resynchronization therapy and left ventricular assist devices, etc. But they're all invasive. So that's the reason why we should stick to these solid indications: heart failure plus COPD, heart failure plus sleep apnea, heart failure plus obesity hypoventilation, for regular use of CPAP at home on a domiciliary basis.
Yeah, Anoop, I hope that answers your question. But I should admit, sir, your point is well taken, that usage of CPAP without relying on sleep study or without ordering a sleep study is quite common, and I'm equally culprit. But point taken, sir, that we should encourage doing a sleep study more and know exactly the problem and probably titrate it better. Point well taken, sir. I admit for your comments. We are having about 7 more minutes in the discussion. I open the discussion for house. If there are any questions from anyone else in the audience to Dr. Vijay, or any other questions or suggestions or comments are there, they are welcome. While you guys are gathering your thought process, may I request Somraju sir to give his comments and suggestions on the topic today. Somraju sir.
Thank you, Praneeth, and thank you, Vijay. It was a very educating experience for me, and I learned a few things on sleep apnea. Though we are one of the very strong supporters and users of, say, CPAP therapy in heart failure and other disorders related. And while saying this, you rightly pointed out the Philips company withdrawing their device the danger that was cited was the polyurethane material they used that was possibly causing cancer in patients. And then it is not yet cleared, and that's one aspect I just wanted to point out. And the risk is cancer. Then the other is related to CPAP, how long it should be used. Patients with heart failure, when you decide to use and when the indication exists, it has to be almost lifelong. It has nothing to do with control of heart failure, and all the parameters become normal. And they continue to be helped by continuing CPAP therapy forever. And other issue I just wanted to point out is these patients, once they are on CPAP machines, the modern machines have a recording system in such a way that they can be remotely monitored. The information can be obtained remotely online, and monitoring becomes easier. I think Dr. Vijay can highlight that on us, and then not every patient needs to be visited once that information is available. Thank you, everybody.
Yes, sir. Thank you for pointing out that particular point. It has got a chip which records several things. It will tell us whether the patient has been compliant in a month of 30 days, how many days he used, and for how many hours he used, and what was the pressure that was delivered. What was the highest pressure that was delivered when he used, and what was the lowest pressure that was delivered, and what was the 95 percentile of pressure that was required for the patient. If this data is obtained, I mean, it can be obtained through the blue chip, through the blue, what you call, through this from directly from the machine to our phones, and also it can be printed. It can be printed and the patient can mail it to us, or through the internet we can access this data so that we know each patient how much he used. So this is a facility, and if the data tells us that the pressures that were required for the patient were very little, then probably that is the time for us to decide that this CPAP machine is not really useful for him. And it also tells us about the apnea-hypopnea index when the patient used this machine. And if the apnea-hypopnea index is less than 5, less than 3, or sometimes even 1, it means that the CPAP is doing a wonderful job. So these are some of the technologies that are coming. But then any new technology is expensive, just like the our mobile phones, more cameras and more resolutions, more memory. We have iPhones which are costing almost a lakh of rupees. We also have a very cheap mobile phone which is just 2,000 rupees. All do the same function, but then more sophistications mean more comfort for the patient and more data available for the doctor.
Sir, if I understood you correctly, you said that the memory card that these machines has, that data is can be retrieved by anyone, sir. It does not require any special software or any. It does not need to go to the respiratory therapist to retrieve the data, sir.
Yeah, so the data is accessible, but then for that, the permission has to be given to that particular doctor, so that the company will arrange. They have a code through that. If you access the code and you get a one-time password OTP, and then once you do that, you can access the data of the patient. So as the patient enters, you can say Congratulations, Mr. Reddy. You have been using the CPAP machine regularly. 96% compliance, excellent. Your apnea-hypopnea index is less than 3, and you have never had any episodes of desaturation. So you can take the patient by surprise.
Sounds very interesting, sir. And do you think there will be any restrictions from the company to give these codes to the treating patient? And how big of a deal is this, sir?
Yeah, it's a very simple thing. It's a very, very simple thing. Only thing is we need the patient's permission for that.
Okay.
He would certainly give permission to his own doctor.
Yes.
And of course, we are all bound by the ethics thing that we will not share this data with anybody else.
Got it. Got it, sir. This is again something which is good to know. I didn't know that we could, because the whole process was that we asked this patient to go back to the therapist, get the data, and then it takes some time to get this data before he gets this data and gets this printout and then come back. But if we can break this barrier and if we can access this data easily, just that the company needs to give a code, I think this also makes life easy for the patient.
Correct.
Yes.
But it will also add work to your routine work.
Yes. Yes, sir. Yes. Are there any other questions or comments from any of the other participants? The chat box also, I do not find any questions. And equally, we are 8 o'clock. Sir, thank you so much for sharing your comments, sir. I think heart failure is quite prevalent, and I think each and everyone deals with heart failure because it's a syndrome in itself with multi-organ involvement, and everybody does encounter heart failure patients with its overlap of other organ systems as well. The points that you highlighted about the usage of CPAP, the distinction of whether this is only a heart failure decompensation or heart failure decompensation with an associated disease, particularly the three things that you highlighted about the association of COPD or sleep disordered breathing or obesity hypoventilation. I think that was a very crucial thing that we should make a distinction. Role of role of sleep study, probably I should say mandatory before we suggest or talk about CPAP therapy in this patient. And the way you said, if this patient has any associated conditions, I think it is worth suggesting these patients to invest on the machine on buying rather than renting, and probably keeping them in compliance. And as Samraji sir was suggesting, that I look at this machine more like an implantable cardioverter defibrillator, like what we suggest, with the so-called technology to monitor and repeatedly doing its monitoring and titration. I get an analogy with the ICD machine that we practice in cardiology space. But I think this equally should be a kind of part of the armamentarium in therapy of heart failure patients, provided we know whom to recommend, when to recommend, and how to titrate, probably closely working in association with a pulmonologist like you, sir. And the point that you mentioned about pulmo at home concept, which is definitely exciting. It is. I get a lot excited hearing this concept. I think this will probably make it very easy for patients and equally other specialists like me who struggle with adjusting these things. I think many points were we learned today, sir. Thank you so much for sharing these insights, sir. It's exciting to have you again in session. And I think there is anything that Anoop you would like to add? Probably I try to cover anything. Anything that you would like to add before we can wind up and close the session, Anoop? Anoop, are you there? Maybe, okay. So I think he's still traveling and issues with his network. So thank you so much, sir. We will close today's session. For the audience, we record all our sessions. All our sessions are recorded and they are put in podcast and in YouTube as well. These are audio sessions which you can use it to kill your dead time. And we host this session every Wednesday. We come up each week with a different topic with a day-to-day clinical scenarios, trying to discuss about the nitty-gritties, making our clinical practice more comfortable and learning from each other. If there are any suggestions from topics that you think we should discuss, please feel free to share us the topics. We equally have a WhatsApp group where we continue these discussions offline once the session is done. Whatever information that we get, we try to put in. So it's again a link that you can join. The link is there in the description. And thank you for participating. Next time we'll again come up with a new session. And for now, I will close the session. Thank you, everyone. Good night. Take care. Special thanks to Vijay, sir.
Thank you very much.